all that meeting. No.
Good morning, everybody.
All that.
My name is Kathe Miller. I'm a delighted family doctor, and I'd like to begin with a question for you. How do we learn to become mentors and innovators? So much of the time it's serendipity, it's on-the-job training. It's really circumstance and happenstance that determines what we learn and how quickly. During my fellowship, I was able to be very mindful about learning how to be an innovator and a mentor, and I wanted to share that with you. It was a process that required a beginner's mind all the time, willingness to be curious and be flexible, and also to be very humble, and let that be okay as part of the process. I'd like to begin, though, well, second beginning, with the story of the family that started me down this path. I'd known Marta since she became pregnant, and I had watched her grow with her child, and then watched her child grow and grow and grow. Anna was a beautiful little girl in the day that I particularly recall starting this notion of a project. She had long brown ringlets and sparkling eyes, giggling all the time as she capered about my office at nearly twice her recommended body weight. As she had been getting older, I had consistently spoken with her mom during our brief office visits about being more careful about what she ate and getting more exercise. It didn't seem to make that much difference, though. I really thought that I understood the problem and the right way to solve it, but apparently something was missing. So in the day in question, I was working with a medical student who I sent in to see Anna and her mom. The student came out very shortly thereafter and told me that Anna was a perfect little child. She didn't need anything except routine well child care. I was dismayed to realize that not even the student recognized that Anna and her overweight was at risk for onset of hypertension as a little child, or type 2 diabetes, orthopedic problems, even bullying at school, not to mention the myriad of problems that she may suffer if her diabetes continued into adulthood, as it probably would. So I went back with the student to take a little bit of extra time to try and understand Anna and Marta's circumstance. As we talked, we learned that Anna and Marta lived in one bedroom of a 3-bedroom flat. There were 2 other families in each of the other 2 rooms. Their only common space was a living room and a kitchen, and when Marta would go to work early every day, Anna would be left at home with whoever happened to be there. She would eat whatever they ate, do whatever they did, which was mostly hang around in the living room and watch TV. And when Marta got home late in the night, she would put Anna to bed, and next day, same thing. Marta didn't have any opportunity to send Anna for any particular daycare. She didn't really know about early childhood care programs. And then I realized that this was a much more complicated problem than I thought. We really needed to think about how all of these things fit together and what we could offer as solutions. So then hatched our project to develop a series of family visits, group visits for families, rather, who suffer from obesity, to try and match up their needs with what is offered at my health center. I work at a community health center in Cambridge. It's a big place, and we offer a lot of services. We predominantly serve immigrants, almost all who are dependent upon government insurance. We have a lot of services on our site. We have, in addition to the medical clinic, a dental clinic. We have a women, infants, and children's office, Cambridge Department of Public Health, on-site nutritionists, Latino and Haitian mental health, on-site social workers, and a Boys and Girls Club. But even with all of these services, we were not meeting the needs of Marta and her daughter. So we launched a project to try and understand the needs of our families and see where they intersected with the services that we offer. One of the first things that I learned in this project was the importance of finding a fit with my students. In previous innovation efforts, I had been working with medical students and residents. This time I was working with undergraduate students, and these extremely bright and enthusiastic women were up for the task, but really did not have the background nor the confidence to take a bare bones project and build it up to something of an end product with the amount of independence that my previous learners had had. So I really needed to back up, reassess my learners, and then provide the sort of mentoring that they needed to ensure their success. So with a little bit more guidance and some more time spent together, we sorted that out, and we were off and running once again. The next lesson that I learned, which was also very important, was about time management. In my previous innovation projects, I had fit the innovations and the work in between and around my very busy clinical schedule. I fit things into the margins, but those margins, which used to be this big, were now very small and really not adequate to do things like write IRB proposals or carry out literature reviews. So I learned that I needed to remove myself from the constant traffic pattern of my office, where patients would sometimes see my back through the door of my office and let themselves in to see what I might be able to do for them. And find a place that was a little bit away from the office where I could kind of hide, but still had my pager on my cell phone in case of a real emergency to be able to get the work done. The final thing that we learned, probably not the final, but the next most important one, was the importance of having reasonable expectations and be willing to change them. Based upon our original plan for this project, by now I would be presenting to you months of anthropometric data about the success or the failure of our project. However, as we took the time to assess our families, build up the assessment tool, and look at the results, we realized that we needed a lot more time. We wanted to create a tailor-made intervention for our patients at our center, not an off-the-rack sort of intervention that was one size fits all. And so we backed off our goals, our timeline, I should say, by quite a lot. That took a deal of humility. It's not comfortable for most of us, particularly physicians, perhaps, to realize that you overshot what you could accomplish. But it was important to set us up for success. So what are our results so far? The first thing we have is a comprehensive guide to all of the services offered at my health center. We created this for each of the services and for the providers so that we can more successfully understand what's available and inter-refer. So far, that's been a huge success, with many people very surprised at the breadth of services and delighted to know how to get patients in. We also created these guides designed for patients in English and Spanish so the patients can self-advocate. The second set of results that we have has to do with the results of our family interviews. The home interviews were the most telling, really. The first one, we went to see a family of 4 out in the suburbs. 4 people living in the living room this time of a 2-bedroom apartment. Similar story, but a little bit different. This time, the mom was at home all the time with the 2 little girls. The dad worked outside the home. The mom had very good access to food, knew how to prepare healthy food as well. But there was no place for the kids to play inside. And anytime she took them out, her husband seemed to find out that she had been out of the house without him. And she would suffer terrible consequences for this, what he considered to be improper behavior. And we were not able to help her advocate for herself and for the health of her children. The second home visit that we did was to a housing project near where I work. As we walked up to the housing project, we saw a beautifully appointed playground, which was completely empty. Nobody on it. As we walked into the 3-bedroom, impeccably clean apartment, all the curtains were drawn. And the kids were crashed down on a big sofa watching an enormous television set. And the mom told us that she was worried that the kids didn't get fed quite enough at school, so she fed them a little extra when they got home. She didn't want them going outside because she wasn't sure it was safe, but she herself didn't feel comfortable outside in the public view. So we realized, again, there were a lot that we could do for this family, but educating on more exercise and healthy eating probably wasn't getting to the root of the problem. So as we plan our series of group visits, what is it that we're taking away at this point? We're taking away that for patient interventions, as well as for mentoring, as well as for clinical innovation, the things that are really most important, perhaps, are maintaining a beginner's mind, being flexible, being humble, and taking all of that to the aim of helping the families that are so dear to us. Thank you all very much.